everybody, and welcome to DEARG, the podcast that's here to educate you about endometriosis and adenomyosis. Today, I'm joined by Orlagh Reid, who is a qualified psychotherapist, specialist fertility counsellor, clinical sexology psychotherapist, and she's based here in Naas in County Kildare. Orlagh does a lot of her work online, and she has a great lived experience with endometriosis and pain. So I'd like to introduce you to Orlagh. And Orlagh, could you tell us a little bit more about yourself, your clinical background and how you got started in this?
Kathleen, thanks for having me on. Yeah, absolutely. It's a pleasure to be here. So as you said, I'm a psychotherapist here in Kildare, and my education, my passion have led me all down, I guess, the whole route of sexology, intimacy, sexual disorders, and really anything in relation to the whole field of sexology. So through my training, I just progressed through different types of training, but they all had something quite similar. So I would have done training around sexual addiction, porn issues, then into fertility, then onto the couples work, then clinical sexology. So I just kept I'm a bit of a training nerd, so I just kept progressing my training, and then the clients that I work with, they are all coming to me for quite similar issues. Endometriosis being one of those, issues around fertility, issues around sexual pain. So endometriosis comes into that very, very often. Sometimes it's the kind of the hidden conversation in the room. Maybe the person doesn't even realize that they might have symptoms. So endometriosis or similar symptoms are often kind of in the background there. Prior to becoming a complementary health therapist, I did work in the corporate world, but since about 2022, I had a really strong interest in complementary health therapies. So I spent about 6 years training complementary health therapies, and then I just really felt strongly that you can work with people on that physical level and that emotional level, but most people really wanted to talk. And when they came into the room, they did want to relax, but a lot of people really just wanted to share in a safe environment. So I guess through my own experience of personal therapy over many years, and then moving into the training, I've just slowly made my way through many different disciplines. And now I guess I combine them all. More recently, I have trained as a qualified coach. And what I'm hoping to do is just really bring that positive element, that lovely neuroscience element into working with women and men with sexual disorder, maybe any sexual pain, anything particularly with couples and endometriosis and fertility. And I guess that whole field of health coaching, which is really quite big at the moment.
It is, and it's one of those things as well that, once you get an interest, and especially coming from a complementary therapy side, like I have an acupuncture background as well as a medical scientist, and you're right, people want to talk. They want to get everything out there, and they see you as a trusted source. And it's lovely then that you've developed the tools and skills to go with that. And one thing that's very close to my heart as well is accreditation and standards. And, I can see that you're registered with your professional bodies and you're keeping up with your CPD. This to me is so important because we have so many people who have access to maybe short courses and don't have that professional body support behind them. So could you give me a little bit about how important that is to you, as a professional, providing this level of very intimate support for patients as well too, and for people? Do you find that a good support for yourself, and do you find that important?
Yeah, listen, I mean, anyone that tells you the route to becoming a counsellor, psychotherapist is easy is definitely wrong. It's a very, very long process. It's a very long process of self-development. We have to have 50 hours of our own personal therapy. I probably had about 80 over the course of my training. And then once you qualify, you have quite a long process of becoming accredited, 450 hours, sometimes with low cost, maybe sometimes with the clinical practice. And once you've done that, you have your accreditation. And then you'll also find counsellors and psychotherapists, they work in a very general capacity. They'll work with those kind of more top line issues around depression, anxiety, low mood, family conflict. So I guess with anything and everything. And then you'll find psychotherapists who specialise a little bit more. So I specialise in addiction and clinical sexology. So all my training is focused on that. And I guess that what that means for people when they go into therapy is, I mean, my advice is if you have something really specific that you need to talk about, go to a very specific therapist. And especially in the field of sexology or psychosexual issues, when that client comes into the room or they come into the online practice, they need you to be asking the right questions, and they really need you to launch into assessment and to put the conversation and to make it immediately comfortable and normal. Because let's face it, most people don't have the awareness, or they don't have the language, or they don't even know how to start a conversation about something that's very private, whether that's sexual pain or I don't know, ejaculation issues, vaginismus. They don't know how to get started. So when you see a specialist, we have in the back of our mind a format to follow. We know the direction of the session. We might know some of their history before they come into therapy. My first question is, have you been to therapy? What have you done up until coming here with me? So you get a really nice picture of where they are in their head, where they are maybe in their journey of self-development or just getting support. So working with someone that specializes, from my perspective, is really, really important. And you know what? It saves you so much time. Because I think I would work with a lot of people who come for counselling for sexual issues, and they will have been with many therapists, but no therapist that they've been with will have said, so tell me about sex. Tell me about intimacy. Do you have sexual pain? What are your symptoms? My approach is very much directive, so I'm quite directive in my conversation. I'm always encouraging. I'm always digging for more information. And I think when it's something around fertility or maybe unexplained fertility, particularly conditions like vaginismus and painful sex, you want to get the most for your client in that first session. You know, usually they have spoken loads, and what they need is just kind of a deep dive into what they're going through and space to just say, you know what, yeah, this is where I am and I just don't know what to do. And they expect you to know what the next steps are. And it's so important for me to feel like I can provide that for people, and to be well networked with whatever organization it is, whatever specialist, pelvic physio it is, whoever it is, you know. So they rely on specialist therapists to get them to make progress far quicker. And maybe my own lived experience of endometriosis makes it much safer for me to say, tell me about this. Have you noticed that? Like, what's going on there? So I bring my own experience into the room with my clients, and we just sift through that and see where they're at.
And it's very difficult, isn't it? When you go into the room first, you go into an online session first, and, you know, we haven't been brought up to understand how therapy works, and we haven't been brought up to talk about painful sex. We haven't been brought up to talk about a lot of issues, and it is very difficult, that very first step. So it's lovely to go into, you know, a warm and inviting environment that, like you provide, you know, through even an online service. You know, it gives somebody that little bit of protection behind the screen, I think, as well. And do you find there are any barriers for online, or do you find that most people find it quite relaxed and are comfortable in that?
So when you look at all the research shows that online therapy is just equally as satisfactory, and outcomes are equally as good as face to face. I mean, we live in Ireland, you know, a lot of people in rural Ireland, they don't want to talk to their local counsellor. They don't want to go to their local GP. You know, they might have access, they mightn't have the finances to travel to Dublin or to go to a specialist. So I mean, that is the wonder of online therapy, isn't it? That it brings therapy to you in your own home. You can be in your pajamas, or you can be on a lunch break. I can't tell you how many clients that I have, and they have their dog on their knee, or they're having their cup of tea, or, you know, they're just sitting with their partner. And there's so much value in being in your comfort space and your comfort zone when talking to a complete stranger about something deeply, deeply private, you know.
That is it. And it's so true, isn't it? Anything that can make that, you know, a little bit safer and feel a little bit safer is really, really positive. And I suppose, you know, from your experience, like, and your experience living with endometriosis and also seeing people who live with endometriosis, you know, we know it has a profound effect on mental health, and it has a profound effect on so many things. It's tied up with our sexual health, and it's tied up with our mental health, and it's tied up with our physical health. And living with endometriosis and chronic pain, is there anything in particular, or any particular psychological challenges that we would face maybe, or does it have a big overlap with the rest of the general population?
I mean, listen, every endo story is different, isn't it? And yet there are so many characteristics for women, and it's not just, you know, the woman that experiences, it's her partner. Sometimes it's her siblings. So, I guess what I would kind of say around that is, psychological pain, prolonged pain, undiagnosed pain, that really strong sense of not having answers, not knowing how long it's going to last, how long can you tolerate it, like your circumstances. In my case, I had two really young children, one with special needs. So when you look at the conditions that people are working in, some women with endometriosis, they might be working long shifts, they might be nurses, they could be guards, you know, there are so many different factors that would influence how a woman can cope with endometriosis. And maybe one of the first things that I would do with them is I look at, like, what are your supports? Who have you told? What are your symptoms? What lengths have you gone to so far to understand maybe what you're going through? Usually what a lot of people present with would be health anxiety, certainly my experience. And look, who doesn't experience anxiety when they're experiencing symptoms of pain and they're not sleeping and they're very stressed and they have less of a capacity to look after themselves, maybe not eating properly. You know, there are so many really diverse factors influencing when somebody has endometriosis. And then maybe the means that they have to get the support, maybe the cognitive ability that they have to get support. If you keep shouting that you're in pain and nobody's listening and you feel like nobody cares and no one is providing you with information, it's a very, very lonely place. You know, not everybody has a partner, not everybody has a supportive partner. And I think that's why having advocates like yourself, having support groups, just being able to have conversations with parents, mothers, sisters to see, are you experiencing this? Is this normal? Pain is not normal. You know, it's not normal. Psychological pain is not healthy. So the more you can kind of reach out and start talking about what you're going through and have people to advocate for what you're feeling and really believe what you're feeling. You know, I mean, I think certainly I don't know how many times I have to say, I'm in pain over and over and over again. And it was constantly dismissed and overlooked and ignored. So it's so important that women get that support, you know, and they're able to talk about what they're going through, regardless of an endometriosis diagnosis.
And I think as women too, we tend to try and shoulder the burden of pain, you know, be that physical or psychological. We try and sort of go, well, we have to carry this because we're women. And that's always the fear as well, isn't it? And I think, again, when you've been told you're not in pain or you may not be as bad as that for so long, you know, and I've heard it's an ex-president of the VSGE, which is an accreditation body for endometriosis centres in the UK, and he described that almost every woman he has met with endometriosis has some shape or form of PTSD, and be that from the delay in diagnosis or for being denied a diagnosis or for being told that their symptoms are in their head as opposed to the pain in their pelvis and the pain in their body, you know. And you can see why advocates like myself and, you know, worldwide, that we are looking for a multidisciplinary team approach to endometriosis. It's not just a gynecological disease. In fact, I question that it's a gynecological disease at all because it has effects in every part of the body. And I think the psychological support is so important in that. So how do you support individuals living with endometriosis and managing like pain, anxiety, or any other emotional symptoms? Can you give us just, you know, very quick tips as to how you would help somebody if I came to you, say, for an appointment? Where would we start?
So we would generally start with just an overall background, history to why you're here, if you've had therapy before. I'm really interested in people's diagnosis and any health conditions that they have in the past. I usually like to bring in the complementary piece. So I love to know, you know, how do you feel your overall health is? How is your mental health? Like, how is your self-care? Are you exercising? Do you eat well? So I think getting that really kind of broad picture of where the person at's really helpful. I would usually ask, you know, what have you done up to this point? So what kind of supports are in place? Because you don't want to be repeating things that they already know. You know, so many people come in and they say, I really know that I should be meditating. Meditation is so far removed from maybe where some people are. And like you say, a lot of women are coming into therapy with symptoms of PTSD. And think about what happened, the impact of PTSD on sexual functioning, or on how you breathe, or on maybe chronic pelvic tightness. Of course, it's going to cause sexual pain or fear and avoidance of pain in some way. So I guess we would also look at how's your intimate relationship, how are you feeling in your relationship. So a really broad picture of where you're at. And I would usually kind of throw, like, this is all about you. It's about the woman coming into therapy. So I want her, first of all, to really share what is her life like? What are you feeling? What are you not sharing? What are you not talking about? Maybe what are you ashamed of? There is a lot of shame that can come with having gynecological issues, or sexual pain, or just, look, there's just so much that could be potentially in the room. So that first step is giving people the space to kind of purge and to just get everything off their chest, and rather than jump into a diagnosis, to create that space. I'll always let my clients know it doesn't matter that you don't know where these sessions are going for the first 2 or 3 sessions. I'm putting all your information like up on a shelf in my brain, and we're going to come back to all of it, and everything that you talk about in your session is relevant, because it really, really is. And maybe those first steps about being in therapy is allowing the woman or whoever it is to maybe just get back in touch with their self-esteem and their confidence, and to hear themselves. I think that's really huge, giving women that voice, and then to start moving and progressing from there. I guess we would always look at, have they had treatment? Where are they in their treatment? What kind of self-care strategies do they have? How is their stress levels? And then how are their anxiety levels? What are their natural coping strategies? Something that I would see a lot would be for undiagnosed pain, or maybe endometriosis that's left untreated, is like, we do what we believe works for us. Sometimes they're really maladaptive coping strategies. Sometimes it might be drink. Sometimes it could be food, takeaways, binging, oversleeping. There are so many ways that we try to self-soothe, and they're not always the best ways. And so I guess we really start with those simple things: self-care. How are you minding yourself? Who are you talking to? And after a few sessions, trying to create a plan or a process around those next steps. And my job is to be an advocate, and to allow my clients to have their voice, so that they can walk out the door or log off and go into their partner and say, you know what, actually, I'm really tired. I'm really tired of what I'm going through, and I need something more to happen.
Like, that's amazing. And it's really empowering the individual again, isn't it? And giving them back the tools, and maybe giving them new tools and a new skill set to be able to use as well. Like I say, we're not, not all born with the tools and the skills to be able to communicate effectively, especially, maybe with an intimate partner, or maybe with another family member, or even in a workplace as well too. It's very, very difficult to communicate if you're in pain or if you're suffering, and to have somebody believe you like that as well. So those tools are fantastic, that, over that period of time, through therapy, that you could develop those skills. And I suppose, from dealing with the sort of trauma that comes from endometriosis, and a lot of medical trauma around that as well too. For first appointments, and we sort of touched on this earlier, like, would it be okay if you had, say a friend or a family member just sit in with you for the first appointment, just so that, you have that wee bit of support, and that you've just that extra, I suppose, extra backup in case things got a wee bit too heavy? Is there a way I can say to you, look, Orla, when we not go there today, like, that's a bit tight, so can we leave it? And is it that comfortable? Can we get that comfortable in a conversation?
Yeah, so what I always say to people is, if you want your partner in on the first session or any sessions, like, I'll always extend an open invite to partners, because we all have different levels of being able to express ourselves. And I don't know about you, Kathleen, but when I go into the GP, I have learned, we forget, we like sometimes it's just really uncomfortable, and it's really hard to express what you're trying to express and get the point across and think of everything, and my mind goes completely blank. So to have a partner in on a session, now I have to tell you, it doesn't happen very often. Sometimes they might come in maybe around fourth, fifth, or sixth session when the client gets comfortable. But I think you get a different perspective of what's going on for the client, and we forget what we're going through. We forget who we've told or who we haven't told, or we forget the symptoms or the sleeplessness, maybe the different appointments that we've been to. So it's really great for partners to have that perspective and have their partner reminding them. And like the idea of inclusivity, it's huge. Like you say, how important it is to have a multidisciplinary team, how important it is to have inclusivity in treatment and in psychotherapy and in any kind of appointment. I think a lot of psychotherapy, it tends to be very traditional, the 1 hour on your own, total confidentiality. And I don't have issues with all of those, but I really believe that we have to be more flexible. When I work with my clients, I offer them half hour, an hour and a half, 2 hours, or sometimes 3 hours. Because if they've traveled or if they're online or they've taken a day off, they want to get as much as they can out of that session. And an hour broken down between maybe me talking and them talking and quiet time, it doesn't leave a whole lot of space. So it's fantastic to have partners in. And even sometimes I might invite partners, do you want to do a session on your own? Because of course issues are impacting them. And maybe, Kathleen, in that instance, it's made clear this isn't relationship counselling. We are working with presenting issues that you're both going through. And it's a lovely sign for partners to come in because it's showing that they're supportive, that there isn't conflict, they're trying to find outcomes, they both maybe want to be heard. So I mean, I'm always advocating for maybe diversity in the treatment plans that we're proposing or just the services that we're offering, and to be more partner sensitive.
And I think that is very important. And you're so right, because there's often times where I'll say, oh no, I was fine. And my partner will tip in and go, no, you didn't sleep for the last week and your pain's been up at whatever, so we do tend to forget. We tend to normalize it, I think, quite a bit. So it's brilliant to bring that into it as well. And, it gives you that extra set of ears. You might take away a different tip than what I've heard, and that's good. And you can recap over the session as well too. And I suppose one of the worrying trends, I suppose, I'm seeing, and in one way it's a good thing and a bad thing, but I'm seeing a lot more younger people being diagnosed with endometriosis and chronic pelvic pain and adenomyosis and all sorts of things. And it's good that we're catching these patients early. So I think that's very positive. So are you able to have sessions with younger clients, or is that something that they would need a parent or guardian with as well for sessions, or how does that work?
So usually, I mean, a couple of years ago, I kind of made a decision to work with clients over 21 years of age. Now, the law states that anyone over 18, everything outside of that's strictly confidential, so partners, caregivers aren't involved in the process. I don't tend to see many clients under 21 or kind of 23, even 25. I guess it's a financial issue. Or else what I do notice is that I think a lot of people suffer with endometriosis or could be menopausal symptoms, explained infertility, like all of those types of issues. They generally, counselling is often a last resort. They kind of arrive in sessions and they're really spent and they're burnt out and they're kind of there as a last resort. Would it be great if parents, partners, encourage them to go to therapy really, really early on? Yeah, absolutely. But I mean, look, if I had a young person come to therapy and their partner or their parent wanted to come with them, yeah, look, I guess you kind of just take every session as it comes. It really does depend on what they're going through, But generally speaking, people will come quite late into the process. A lot of people will come to therapy maybe after they have had maybe unexplained infertility, they've been through the IVF process, they've been encouraged to get counselling. So therapy or counselling is very rarely the first port of call. I think it's great to hear from your perspective that people are being diagnosed with endometriosis earlier. And maybe I'm thinking about that from the fertility counselling perspective, because so many people that I'm seeing, they're in their 30s, 40s, and had they had a diagnosis 10, 15 years earlier, they wouldn't be in the position to be getting IVF in their late 30s, early 40s. Or, if we had the correct services in place, if we had better screening, if we had better awareness training, all of those things, there wouldn't be so many people struggling with IVF and IVF treatments and everything that's coming now with this huge surge that we're seeing. I mean, look, it's been surging for maybe the past, in my experience anyway, since I've started about 5 or 6 years ago in fertility counselling and assisted reproduction. But yeah, it's great to hear that they are getting diagnosis early on. However, I have to say though, I hear a lot of people that say, no, my GP said I'm fine, the ultrasound said I'm fine, the transvaginal ultrasound said I'm fine. And we know from research, and I know from my own experience, a lot of those screenings show up clear, that a lot of the time endometriosis, you can't actually see it on the likes of ultrasounds and MRIs. So if you don't believe and you still have pain, I would always encourage second opinions or further investigation, and not to assume that what you're being told is 100% accurate. So yeah, I would always advocate for just trust how your body is feeling.
And I think that's one of the positive things about this. Certainly the younger generation at the minute, they're very comfortable in speaking about their bodies, and they're very comfortable of advocating for themselves. And they're able to find good resources online, which is quite good. But you're right, we need to recognise this early. And this is where our education of not just young people comes in, but our education of healthcare professionals all across the board comes in as well too. And I think that's so important to be able to recognise endometriosis. Recognize it in people. If I can recognize it in somebody after a quick conversation, and I know I'm dealing with it all day, every day, but we should be able to impart that knowledge to everybody else as well too. And we can all do it one step at a time by talking about it and normalizing the symptoms around that we can say to people, look, this isn't normal. If you're experiencing this, it's not normal. And I would love to see a situation where I have a young person who is attending their GP and they're referred to gynecology ahead of being referred to psychiatric services, because that's what's happening in some cases. They're being pushed right down the like the psychological side and not being believed for the physical side. You'd love to see a situation where you present to your GP and they say, look, okay, I can see the trauma you've gone through with this pain. Okay, let's get it investigated from the physical side. Let's get you started on the emotional support side as well too, to give you that sort of skill to cope with it. I think that would be fantastic. And, you've touched there in the fertility and the fertility counselling side too. And this is huge. And, when we look at the way the IVF clinics are now, going to be able to give certain sessions to certain groups within the community, it's a positive. It's a long way off what's needed. But one of the disturbing trends I've seen over the years is that, people are at the end of their IVF journeys. And like you say, they come to you for therapy. And I'm only seeing them as well too, because they've gone through loads of failed cycles. And only now they're investigating endometriosis. And we know endometriosis and adenomyosis are one of the leading causes of infertility. But it seems to be lost along the way. And you're right, that whole sort of early diagnosis and getting that ahead of time before it becomes an issue, is very, very difficult. And do you find, would you work a lot with GPs? Are you able to sort of reach out to GPs and say, look, refer patients early, give patients information early, like, get them across to you. And, even from like the gynae or the fertility clinic point of view, are they cooperative? Do they see the role of therapy?
Yeah, absolutely. They really do. Now, I mean, I could do that, but I don't do that. And I guess probably just because I'm working online, and this is the one of, I mean, look, there are lots of amazing things about the internet, and being able to work online, and for people self-diagnosing, and that huge array of information. So many women are better able to self-diagnose, and that is a really, really positive thing. But self-diagnosis without getting the right referral, the right treatment, talk to the right professionals, is problematic, isn't it? So the people who I get most of my referrals wouldn't actually be GPs, but it might be gynecologists we would refer back and forward. And actually, interestingly, much more specialist pelvic physios. I would do a lot of referring back and forth, and that's great to have that multidisciplinary team. Like you, I would love to be a bigger part of like a lovely big team, and that it's just normal. You know, you have your treatments, and then you go and talk to your therapist, and everybody knows or kind of has the same notes, and we're all working with the same plan. And I mean, I don't know how many women I've spoken to, and they've said, I really hate having to go through this again. I've gone through it over and over and over again, and you know, I feel for them. I do. I've done it myself. I suppose one of the things that I would notice with fertility clinics is there's such a huge influence and conversation in fertility that is creating huge fertility anxiety for women, really and truly. And fertility clinics, look, they do amazing work. Nobody can dispute that. But at the end of the day, they are corporate businesses. And, you know, to say that, you know, if you don't get pregnant within a year, come to us, or, you know, try for a year and then come to us, the amount of stress and anxiety that women are experiencing because they're like, it has to be our next option. Obviously, it's our next option, but actually, no, it's not. Sometimes they're happy to wait, but they're feeling the pressure, or they're getting the information, or people are saying, go and do IVF. You know, so I think we really have to mind ourselves when we're going through something really complex like this and try to filter out all the noise and work out what feels best for me. What do I want? What do I need? What do we need around our services, around the treatment that we want in our body, around, you know, our planned parenting journey. And I mean, it's hard because there's just so much information. And I was listening to you on your podcast, and like you said, this unsolicited advice. I mean, it's just, it feels never ending, doesn't it? Which is why it is so important to be listening to conversations with experts and people with facts and scientific data, and people who do have your best interests at heart, you know, and are prepared to really listen to you first and then ask you what next? You tell me what it is that you want. So that's huge, isn't it?
It's massive. And I'm still seeing young women coming back and saying, oh, I've been told I need to get pregnant within the next year, you know, and you're like, okay, let's just dial it back here and look at the facts, look around this. You know, over 70% of people with endometriosis will conceive, you know. So again, it's a very individual thing. And we know with endometriosis, there is, you know, significant impact, you know, with egg quality, and also, you know, with implantation. And then you've got all of the bits and pieces that go along around that. And that's not dismissing that side as well. But there is also that very, very real pressure. We have a societal side, we have the online influencer side, we have the commercial side. And there is times where you just feel a little bit overwhelmed and sort of bombarded by it, don't you? And you think, oh, I should be getting pregnant now, you know, and if I'm not, what's going on?
Of course, so we have Dr. Google and, you know, scrolling, and influencers and people who are, you know, just giving very top line information. And I think how important it is for somebody to be able to sit down and just get it all out. Because I guess being in therapy, it's emotive, isn't it? You know, it's working on the psychological, the feelings, the emotions, somatically, how you're feeling in your body. So to have that space just to try to align your thoughts, it's quite hard to do that if you are experiencing prolonged pain. And something came to my mind just when you were talking there. Diagnosis around endometriosis or pain, sexual pain, like all of those things that come with it, they're not things that we tell our peers or our colleagues in work. You know, we don't share that at the coffee machine. We don't want managers to know that, because it might influence promotion. Or, you know, there are so many reasons why people mask and don't share what they're going through, and maybe rightly so. You know, we know our environment and the people around us better, so to have the right services and maybe a therapist to work with, or the physio to work with, that you can just let it all out, you know, it's crucial in terms of overall treatment.
It is, because we do have to put on that face, don't we? You know, and be it the, you know, the sort of, you know, again, coming from that sort of, empowered woman thing, that we can't show any sign of weakness, or be it that, we're going to be influenced in work, it's going to affect our work or whatever. There's always that. Or, even sometimes you feel that you might go into a shop to buy something and you've got endo belly that day, and you're thinking, oh, that person's judging me because I look like I'm 9 months pregnant, but I'm buying like skinny jeans. And you're like, should I tell them? Should I just offload my entire story to them? And you do feel a wee bit like that you need to get that safe space in which to share the story, and also share those frustrations. And the endobelly is one of those things that comes up quite a lot for women as well too, and they're out and about, and it's happened to me countless times. And somebody will congratulate you, and on being pregnant, and you're like, no. And you feel bad for them because there's no malice ever meant in it. But again too, that's something that usually we only ever discuss that with other endometriosis patients.
Yeah.
And, that's something I'm sure that me and you could have a great conversation around, as to why that triggers, and how we respond to that in a way that we don't compound any damage that's there already. And I'm sure you have tips around that.
Yeah, I think that one of the challenges about having endometriosis, or the really chronic heavy periods, or the pain, all of those things, is that, when you look at the likes of advertising, tampons, oh God, just even movies, love scenes, like you're very much can feel left out of that. Because I don't know if we can say this because the only people listening to this probably will have endometriosis. They don't make tampons for women who have endometriosis and heavy periods. It's just, they just don't exist. So yeah, I don't know how many women I've said, listen to or talk to, and they're saying how aggravating those ads are. Like all of these. So I think when you have this condition diagnosed or undiagnosed, as often as the case is, you can feel very isolated, can't you? Very much kind of left out or feeling different. And so the loneliness and that can come with that, and managing pain, it is important to have support, and to not feel left behind, because when you feel left behind and you're not being heard, self-esteem starts to drop, anxiety increases, like all of those psychological impacts of having a condition like endometriosis. I mean, they're huge. And sometimes you can have the treatment for the endo, but the repercussions around the health anxiety persist, or the post-traumatic stress persists. So there has to be approach from that holistic model, the holistic perspective, doesn't it?
It does. Oh, look, 100%. And you'll have heard me chat to Heather Godone about this, and I'm such a fan of the 1% theory, and like that's basically, if you wear orange knickers, you go to therapy, or whatever you want to do that gives you that extra bonus, brilliant, go for it. And I think that the narrative has got out there amongst some media articles and some communities that, you have your surgery and you're cured, off you go, you're out skipping through the fields and those Tampax ads. No, that's not going to happen. There's a wee bit more work involved, and if you've lived with the disease for 25 years, 30 years, 19 years, whatever it is, before it's removed, you've got all of that inflammation, you've got all that psychological pain, you've got all that trauma, you've got all that stress, and you've got all of those ingrained habits that you had mentioned earlier as well too. Those coping strategies have now become embedded, be it stress eating, or be it, dependent on alcohol, or whatever it is, we've embedded all those things. So, surgery step one, pelvic physio, psychological support, dietary support, all of those things come into it, don't they?
Absolutely huge, aren't they? And again, there's also, I feel, a lack of information around the post-diagnosis, isn't there? I do loads of work with women who have vaginismus and sexual disorders, maybe fear of pregnancy, fear of miscarriage, all of those things. And just some of those basic treatments around, using dilators, beginning to use tampons again, like anything that might instigate pain, or even the anticipation of pain, like all of those get very much embedded in the psyche. All of those things impact partner intimacy. Like all of those things need to be unraveled, and nothing around kind of psychosexual issues or sexual disorders is quick. And I mean, I'm always explaining that to people. There is no quick fix here when you're dealing with sexology or maybe developing sexual health. It is a slow burner, but they are lifelong skills. You won't regret it. You'll get to know yourself. And back to what you were saying earlier, those coping strategies, they have to be so personal, because what works for you, I might think is ridiculous, and what works for me, the next person might think is really fluffy, so we have to, it is an intimate relationship with ourselves that we're working on in therapy, and that you can go outside then and be able to talk more and work out and experiment and see what works for you in your treatment. And I always kind of encourage clients and even remind myself, we're not aiming for feeling great and amazing and, like you say, skipping through fields. Sometimes just trying to feel better is enough. If you have really severe endo pain and you have to stay in bed all day, just being able to make yourself a dinner, that's enough for you on that day. So not judging where you're at and where other people are at is huge.
It is, and it's allowing ourselves to experience that pain as well too, and experience how we're feeling, and not, shove it down there and sort of go, no, Grant, fine, I'm going to get up and I'm going to battle through it. And yeah, we do need to listen to ourselves quite a lot, And in terms of, coping strategies and that, like, they're all so different, and I've heard loads, and I'm sure you've heard so many over the years. And in terms of ingrained behavior that might be negative, is it difficult to change something like that? I know it'll take time, but is it very hard to turn something like that around? So, for me, like, it's bite my nails. It's terrible. Like, that sort of, but it's a stress thing for me. Or, I've seen people as well too, like, it could be pulling their hair, it could be, like maybe a stress eating, another one of mine. So is it very hard to turn those behaviors around, or is it something that you constantly have to work on?
I don't believe that it's hard to change any behavior, and I guess my coach mindset says that we have the capacity to change our behaviors and change how we think and be really, really creative and inventive in how we mind ourselves and how, any behavior that we've created, that we've been doing, I guess has probably served a purpose. And so when you start to develop awareness and then maybe self-awareness and a deeper awareness, we have the capacity to change pretty much anything, in terms of how we think and the routines and rituals that we have. So I'm always encouraging people, so what's working and what's not working? What do you want to work? Where can you see yourself going? Like, what do you think is going to help you? And trying to get clients to make those decisions, from their own capacity, because I don't really know what's going to work for them, but my clients will know. So I'm working from a psychotherapeutic perspective and that coach perspective. But look, there are things that we know work. Anything that's going to help anxiety, anything that will help low mood, anything that improves well-being. It could be complementary health therapies. It could be walking your dog. As long as it's something that's routine and consistent and perpetual, and something that you feel invested in. The likes of using calm apps, journaling, showers, hot baths, like all of that thing, all of those types of things, they all work, don't they? Are they the answer? No. Do they make you feel a little better some days? Yeah, so it's just trying to, as long as you're invested and you're investing, you will find ways to mind yourself and to manage what you're going through.
It's really being conscious of it, isn't it?
Yeah.
And, being honest with yourself, I think, as well too. And, again, keeping the lines of communication open with those around you. And to sort of keep that feedback, I think, from people as well too, that if somebody does say to you that they think maybe you're overdoing it a wee bit, or you should take a rest, rather than react and sort of go, oh no, I'm fine. Maybe step back and think, well, hang on a second. Now, Orlagh had told me that, I can use the tools to sort of work around this and, get myself back into a nice calm state and do something for myself and not feel guilty for a bit of self-care.
Yeah, and you know what, I will often have clients say to me, so in the last session you said this, I didn't realize that, or I didn't like what you said there. And as therapists, we're not there to, like, make the person feel good all the time. We're there to help them to be real and to be honest and to reflect back what they're going through. And of course, we're there for their overall well-being. But a lot of people, it's only when you reflect back what you see or the patterns, like a lot of the time we just don't notice things that we're doing unconsciously. So often I might get a client say, I didn't even realize that I was doing that, or I forgot, or, when you're under prolonged stress and pain, we're not thinking clearly. We don't have the cognitive capacity to mind ourselves the best way that we can. And so to be able to sit with a therapist or a friend or someone who's been through it, they can see things that we just can't see, So it's huge in terms of that openness, and it takes vulnerability, doesn't it, to even have this conversation or to share where you're at. That open conversation it's huge.
Oh, it's massive. And, I think that first step is making the appointment, isn't it? And sort of thinking, okay, right, I like the look of this person and I think they're going to be good for me. And, okay, right, I'll book with Orlagh now. And, you'll sort of debate over it for a while. But again, I think once you take that first step and you have that first conversation, and none of us like to hear that sort of feedback or criticism about ourselves. But again, I think when you take it back with the tools that you're given, and start looking at it and starting focusing, like, okay, can I use this then to improve, whatever aspect it is you're working on, like, that sort of way. And, you have an end goal in sight. And you're right, we're never going to be perfect like the ads on Instagram, but we can be the best version of ourselves. And that could be different every single day of the week. And you've touched on that, And in terms of, just on your own sort of story as well too, how do you find that your holistic training and your professional training, how do you find that they've both come together to help you with your endometriosis journey?
Yeah, so I was sharing that with you on my blog that I've been able to share and just kind of put out there. And it's kind of scary, isn't it, sharing your own story? And then sometimes I think, you know what, nobody cares. Really nobody cares. And the only people that will be reading it are people who maybe are trying to explore and understand their own symptoms. So for me, look, my story is, I guess, quite similar to a lot of women's, but then it's also a little bit unique in the sense I had no idea that I had endometriosis. Even though there were signs that were there, it never entered my mind that the pain, the lower back pain that I was experiencing was endometriosis. It was the furthest thing from my mind. So I was really shocked to find out that what I had been experiencing for the last 2.5 years was endometriosis. And so I guess what had happened to me was that when I was 4 months pregnant into my second pregnancy, I was sitting on the couch and I went to get up off the couch and I had this really intense stabbing pain, and followed by about 3 days in bed. And I just thought that I must have pulled a muscle of some kind. And so I went to my GP. They said, pregnancy, don't worry about it. And all through that pregnancy, I had many, many appointments, and like my pain progressed and I couldn't walk, I couldn't stand up straight, I couldn't sit down. It was just really awful, lonely, painful experience. So I had huge anxiety, and I guess it was very much masked by being pregnant. Oh, that's just pregnancy pain, pregnancy symptoms, sciatica, don't worry about it, it'll go away. And I guess it didn't go away, and after my little boy was born, the pain progressed and it just continued to get worse, and the pains, insomnia, sleeplessness, it got really, really bad. But I was going to my GP, it was just being dismissed over and over again. And my sense was they're looking at my history. I have a history of anxiety. She's just anxious. She's a relatively new mother. She's got 2 young children. She's overwhelmed. You're fine. Back out the door. But I think with my history of complementary health therapy and just knowing for me the importance of it and how valuable it is, I thought I'm going to go and really understand what works for me. I'm going to find an answer. I don't care what it takes. It's hard to get time for appointments when you've got 2 young children. So look, I went to like yourself, acupuncturists. I went to 2 different chiropractors. I went during pregnancy and after. Physical therapy, physiotherapy, massage therapy. I literally did everything that I could. And most of it helped in some way. Sometimes it helped me sleep for that night, or it was short-term relief, but ultimately the pain was still there and it was still progressing. So if I didn't have that, I really don't know how I would have coped. I think psychologically the distress would have really increased. So I would encourage people, like, see what might work for you, experiment and be really creative, listen and search and see what's out there. Who's talking about this? Who has services? Like, who deals with pain or lower back pain or chronic pain? My symptoms were very isolated. I had lower back pain on one side and it radiated all through my body. And so even though the GPs were very, very dismissive, and I had absolutely no help from them, and I left in tears every time, I was still really determined to get myself the whatever it was. And by chance, about 2 years in, my sister had told me that she had just been to a gynecologist and to just go see him, so it was a really sporadic, sure, I've nothing to lose at this stage. And when I went into him, his first question was, "Oh, your sister is, so do you have endometriosis?" And I said, "No, just this pain." And he asked 3 questions. And he said, "Yeah, I'm pretty confident it's endometriosis. Like, all the signs are there." So, I left feeling relieved and grateful. And I wanted to hug him. I was so happy that he had identified with me and gave me some acknowledgement or recognition of what I was feeling for 2.5 years. And then I got really angry. Furious. Like, I can't explain the inner rage that I felt. I was so angry. Not at anyone in particular, my GP 100%, because the symptoms and the signs of endometriosis, they're not really, it's a complex condition, but essentially the symptoms and signs are relatively, the main symptoms are relatively straightforward. Heavy periods, lower back pain, abdominal pain, radiating pain, complex pain, like, they're all in a very, very similar area. So I got really annoyed that I wasn't asked more about what I was feeling, because I think had I been given the time, had I been asked, had I not been dismissed, I could have had that, that treatment 2.5 years before. So what happened for me then was, a month later, I went in for treatment, laparoscopy, diagnostic, and he said, yeah, endo, exactly what I expected, endometriosis, adhesions. I'm trying to think what the results were, but essentially the endo had embedded my ovaries and the tubes into the uterus. So hence the kind of all the chronic pain and the radiating pain. So as I got more pregnant, it was really aggravating the endometriosis, and progressed and got worse and worse. So, I've had very little pain since that treatment, and that was, thank God, the end of that pain. But the after effects, and like you say, how long it takes to recover from post-procedure, post-diagnosis, it's a long, long time. The anger has never really gone away, I'll be honest with you, which is why I love to advocate for endometriosis and work with women with endometriosis and maybe help them build their voice around endometriosis. Does it mean endo is gone? No, I think we all accept that it doesn't disappear. Sure, it doesn't. I'm in my 40s now, so my symptoms have changed quite rapidly. And it's very surprising how quickly different symptoms can progress. So the symptoms I'm dealing with now they're very, very different. But it's very different being in a place where you have a diagnosis and you have an idea and you kind of know where to channel your energy than having nothing. I presumed I just had sciatica or something wrong with my back, but really deep down I knew it was something very, very different.
And it is, and you've touched on one of the real things that I've come across in the 25 years speaking to women with endometriosis, and that's that anger. And it usually doesn't go away, trust me. 25 years later and I'm still raging. But the thing is, we can use that for something positive. We can use it for change. And, you're doing amazing work with clients, and that's, so powerful and so positive. You're empowering them then to go on to develop their own tools and skills to cope with their own anger as well, which is brilliant. And it also gives you a channel then for raising awareness and, also sort of providing that advocacy as well too. And, advocacy takes so many different roles, doesn't it? And when I chat to people and they say, oh, but, you're able to talk about endometriosis to anybody, and I couldn't do that. And that's not what everybody needs to do. Advocacy for you could be that you're advocating for yourself in front of the GP, or advocacy for you could be, going on radio and telling your story. Whatever it is, everybody has to find that level. And, the frustration with that delay in diagnosis, and that, I suppose compounded the fact that nobody sees it, nobody recognizes it. Yeah, it builds that fire, doesn't it? And it does take us a while to come around from it. But when I get my magic island and we have our endometriosis treatment centre and we have the different specialties all together, we won't have to worry about that, because we'll be diagnosed in the first place, and then we'll just go around all the different therapies and we'll be cured.
Yeah,
That's the dream.
It's great to see, and like this podcast is huge information, isn't it? And a space for women to go, or partner to go and just listen and get facts and listen to it from very different perspectives. Listen, I don't know about you, but just the trend in conversation in Ireland for women around menopause the past year, it's been huge. And I think on a few levels, it's given women permission to just forget about what people are saying or what they might say, and be able to have those open, honest conversations. Thankfully, endometriosis kind of ties into, it's a similar area, isn't it? So the more you can kind of have those unashamed conversations, and just, it is what it is, I mean, we can't change it. It's not going anywhere. Women's sexual health is look, it's such an important part of us, isn't it? And so the more we're advocating, the more we're talking, the more open, honest dialogue there is, the better for everyone involved. I mean, when I think of my family, my four of us in my line of siblings have endometriosis, so I have to presume that maybe my children will have it. So if I don't do this now, we have to really seriously consider what are we willing to do for the next generation around sexual health, sexual disorders, our whole healthcare system. So, I mean, like you say, yeah, anger can be really, really positive, and I guess I'm channeling it into, what next? What can I do? What can we do? So, I'm delighted to be a part of this podcast and to be in the conversation.
No, it's been fantastic to have you on as well, Orlagh, because the more strong voices that we have, and, we've enough medical information out there. There's plenty of that. But what we don't have in Ireland in particular is very open and honest conversations around endometriosis. And this time last year, in fact, just a year ago, we held the Below the Belt screening in Dublin. And the previous, probably 5 or 6 years before that, I hosted the Endo What premiere in Ireland as well too. And that started off a whole conversation, and Joe Duffy covered it for the whole week, and there was great crack and chat and everything about it. And women were really, really laying themselves bare. But where I felt with that was they were left hanging. Mm-hmm. There was a great outpouring and all of that, but there was no follow-up. There was no hope left in those stories at all. And, that's always the worry, that if you don't know where to go after you've had this release, well, you have that worry about that anger going back inside again and becoming a more destructive thing. So this is why I think hopefully with the DEARG podcast, we'll be able to get professionals like yourself out there showing people that there are options, and even for people like me who were scared away from therapy all those years ago, I can be encouraged to go back, because I now know that things have moved on enough and that there are understanding people out there. And I think that's massive, Orlagh, I'm just conscious of our time here, and we have had such a great conversation. And what I'm going to do is I'm going to link your website in the show notes, and people can get in contact with you through that and make any bookings or appointments. And, if they have any questions, I'm sure you're happy to take them as well.
Absolutely. Thanks. It's been a pleasure and a privilege, Kathleen.
No problem. Thank you so much. And thank you everybody for listening again to this episode of DEARG, and we'll chat to you all again soon.